Okay, so today we're talking about somatoform disorders, and with somatoform disorders, the essential features are that there's some kind of internal psychological conflict going on that assumes a somatic or bodily, physical form, okay? So psychological conflict is manifest through bodily a bodily expression through some kind of physical form. There are several different kinds of somatoform disorders. So first there's hypochondriasis. You may have called someone a hypochondriac in colloquial terms, but in the clinical sense, hypochondriasis means that these people have an extreme fear of disease, and the fear persists despite medical reassurance to the contrary. So people who have hypochondriasis often engage in doctor shopping, where they go to multiple different doctors because they are so concerned that they are, dying, that there's something really, really wrong with them. Oftentimes, too, the social relationships become very strained here because the individual is preoccupied with the condition and expects special treatment from other people. With hypochondriasis also, the hypochondriasis is not fully explained by the presence of a general medical condition, and also the physical symptoms aren't intentional. So people who have somatoform disorders in general aren't faking their symptoms. They're not trying to intentionally show some kind of symptoms with the hope of gaining something. That's called malingering, when you fake your symptoms for some kind of gain. These people really do believe that they have some kind of physical problem. Another kind of somatoform disorder is called body dysmorphic disorder. And with BDD, or body dysmorphic disorder, there is some kind of preoccupation with some kind of imagined defect in appearance. People who have BDD frequently check the defect, so they might have, special lighting to look at how their nose is so messed up. They might have a magnifying glass where they look at particular facial features. And this can consume hours per day. They might have very intense grooming rituals, things like excessively combing your hair to cover some kind of defect, ritualized makeup application to cover some kind of defect. And they believe that other people notice the defect too. And so because of this, because they believe that other people notice the defect, they often avoid normal social interaction. Now, compared to eating disorders, where there is also, this imagined defect in physical appearance, or you become grossly obsessed with your physical appearance, with body dysmorphic disorder, the preoccupation is with some kind of non-weight related site, so like your nose or your ears. If it's an eating disorder, though, the person becomes more obsessed with body image in a weight-related body site, such as your waist, your hips, or your thighs. So that's one way to be able to distinguish. Additionally, with BDD, we don't usually see the eating disorder symptoms, such as excessive dieting, weight loss, purging, feelings of loss, or control surrounding the food. So with body dysmorphic disorder, you'll see on the home page in Blackboard there is a case study, and I want you to read the case study and then try to answer these particular questions. So what kinds of specific symptoms of body dysmorphic disorder does the girl in the case study actually show? And then how does the therapist try to explain her BDD using a psychodynamic perspective? So what specific psychodynamic tenets does she use to try to understand how the client's BDD developed? And then what kinds of cognitive behavioral techniques does the therapist use to actually target the body dysmorphic disorder? And then within the case study, there is a 5-axial diagnosis that is provided. So I want you to think about why the therapist might see the psychosocial concerns that are mentioned on axis 4 as relevant to LG's treatment. Why might these things be important? Other somatoform disorders include a disorder called somatization disorder. And with somatization disorder, there are numerous and recurrent physical complaints that begin by the age of 30. They persist over several years, and they cause the person to seek medical treatment, but the symptoms cannot be explained medically. So there is an absence of medically objective findings to fully explain the subjective complaints. Usually the complaints for people who fall into this particular diagnosis are clinically significant if they result in medical treatment or significant impairment in social, occupational, or other functioning. And with these individuals, there's a history of complaints related to at least 4 sites or functions on the body. So, for example, individuals might complain of gastrointestinal problems such as bloating, nausea, vomiting. They might complain about problems with menstruation, with sexual activity, with urination. And the symptoms are not intentionally produced, okay? So these people, again, they're not malingering, they're not creating these symptoms to, have some kind of external gain. They truly do believe that they are suffering from these symptoms. Additionally, this is often comorbid with other anxiety disorders, so oftentimes exist in conjunction with depression, with substance abuse, with panic disorder, and these individuals are likely to seek treatment from multiple doctors at the same time. They might also be on multiple medications to treat these different areas of concern within the body. Pain disorder is another somatoform disorder, and essentially with pain disorder, this diagnosis is given when the individual experiences pain that's more severe or persistent than can be explained by general medical causes. So for pain disorder then, the psychological factors are assumed to be the result or the cause of pain. So pain is the disorder rather than a symptom of the disorder. They describe the pain in very emotional terms, and this pain, oftentimes this particular disorder leads to consequences such as unemployment, disability, extreme problems within the family unit. Additionally, these individuals often have a history of substance abuse or dependence, and oftentimes pain disorder may exist comorbidly with mood disorders, particularly with depression, and also with anxiety disorders as well. Conversion disorder is another somatoform disorder here, and with conversion disorder, there is a disability that does not have an organic pathology that would explain the disability. So for individuals with conversion disorder, there's some kind of problem with motor or sensory functioning that suggests that there is some kind of underlying neurological or general medical condition that is causing the disorder. However, there are psychological factors that are the actual cause of the disorder, and you can address this because the symptoms are often exacerbated. They're worsened when the individual is under stress or when the individual is under conflict. You only make this diagnosis after there's been a thorough medical evaluation that rules out other causes. And oftentimes the symptoms are very inconsistent with one another. So for example, an individual with conversion disorder might have an arm that appears paralyzed. And we use that term paralyzed in quotes, right? Because the cause is psychological as opposed to a physical cause or organic pathology. Oftentimes, again, these symptoms are inconsistent. So this paralyzed arm may move while the individual is dressing. So that gives us some indication that there's not an underlying physical cause here. The cause is actually psychological. For individuals with conversion disorder, there are some particular gains that they might experience. So the primary gain relates to the reduction of anxiety. So if we believe that there are underlying psychological causes, psychological conflict essentially, that are causing the presence of this conversion disorder, the individual, by converting the psychological conflict into a physical problem, gets a reduction in that anxiety. They can resolve that conflict in that way. Secondary gain may also occur where individuals become excused from their responsibilities, or they attract sympathy or attention. They get some kind of external benefits, and they can avoid responsibilities as a result of the particular conversion disorders. When you're trying to understand where conversion disorders come from, or what are the particular signs of conversion disorders, the differential diagnosis is really difficult, and you have to rule out malingering. So you have to rule out, is this person intentionally faking symptoms for some kind of external gain? And you also have to rule out if there is any kind of actual physical cause that needs to be addressed here. Conversion disorder is actually really rare. The diagnosis may be rare, and the symptoms oftentimes go unnoticed. With this idea of la belle indifference, a true conversion disorder, patients are often unbothered by their symptoms. When patients are faking, when they are malingering, oftentimes they're very upset over their symptoms, and so that can help you kind of distinguish between if a person is faking, if they're malingering, or if the person actually does have a conversion disorder. So in talking about where these different disorders come from, if we look at the psychodynamic perspective, we can say that these individuals are trying to resolve this psychological trauma, psychological conflict by expressing their pain in some kind of physical form. So their psychological pain takes on a physical form, even though there's no organic or physical basis for the pain. With the behavioral perspective, individuals who suffer from somatoform disorders enjoy the sick role. They enjoy the benefits. They're basically rewarded by reduction in responsibilities. They get to abdicate, the normal things that they would have to do every day because they're sick. Somebody else will take care of it for you. So in trying to treat somatoform disorders, a behavioral perspective emphasizes non-reinforcement of the sick role. So basically, you don't provide any kind of reward for showing this kind of sick role behavior. You don't get out of your responsibilities just because you're sick. With the cognitive perspective, again, cognitive perspective looks at thinking, right, and how you interpret your bodily sensations. Cognitive perspective states that individuals who suffer from somatoform disorders are overly attentive to normal bodily sensations. They exaggerate these sensations, and they catastrophize very, very minor symptoms. And so the treatment then is to challenge these faulty beliefs. So cognitive therapy, you basically need to test these explanations that the client is giving, challenging the fact that these minor sensations, these minor things going on in your body are likely not indicative that you are dying, for example. With the biological perspective, many different things going on here. Again, looking at genetic studies, we see that with family patterns, oftentimes there are family histories of these somatic complaints. So they appear to run in families. There may also be some kinds of problems in processing sensory signals in the cerebral cortex. It appears that in individuals who have somatoform disorders, that these signals in the cerebral cortex are often suppressed. There may also be some kind of abnormality in serotonin functioning, and we know that serotonin is related to feeling good. Serotonin is also related to mood. Biological treatments are scarce in terms of looking at drug treatments for these individuals, again, because the problem is psychological and it's being manifest in a physical form. So using some kind of, say, pain management is not going to be very effective for individuals who have somatoform disorders. Sometimes, though, individuals can benefit from the use of antidepressant drugs, again, to treat the underlying psychological causes.